Your echocardiogram, everything in echo is gated. And what we mean by gated, everything in echo is either systole or diastole. Okay, you can't just do an echo without putting on your ECG leads and know whether it's systole. So it's either systolic phenomenon or a diastolic phenomenon. So you have to know ECG, and then you're going to get ECG in the echo exam. If the patient comes to the echo lab and they're in atrial fibrillation, you need to know that because you're going to get certain readings, especially your Doppler. So you need to know to interpret basically EKG, ECGs, nothing eye powered. And then if the patient is in certain arrhythmia in the lab, you need to alert the physicians, okay, especially significant blocks. All right, so when we say EKG, ECG, what are we talking about? What we're doing is looking at electrical activity of the heart. And by looking at the electrical activity of the heart, you can get a lot of information from that. Okay? This allows us to make certain diagnoses or to suspect some abnormal conditions. And these are some of the diagnoses that you can make. You can make a diagnosis of myocardial infarction, and this is ST segment elevation myocardial infarction, and it's very important because there are different types of myocardial infarction. So myocardial infarction is a heart attack, and there are different types of heart attacks, but the one that the ECG is going to help you to recognize is the ST segment elevation, and we'll go over all of this. Okay, so these are terms you're going to hear, and we'll go over them. You can also diagnose myocardial ischemia, that is when there is decreased blood flow to the heart muscle. Arrhythmia, which is abnormal rhythm, the EKG is very good for that. You can also, if you suspect electrolyte abnormality, the EKG sometime, or the EKG ECG will show you some abnormalities there. So things like iron low potassium, iron low calcium, you can look at the ECG and you'll see some abnormality. Chamber enlargement, such as the atrial size and the ventricular size, if they're enlarged, you can also determine that. The heart rate, okay, so you can quickly look at ECG and determine the heart rate. And if the heart rate is very low, then the patient may need a pacemaker. Or heart block, you can also diagnose heart blocks, and patient may need a pacemaker as well. Certain drug toxicity, digoxin toxicity, and then some of the drugs we use in psychiatry, they can cause what we call QT prolongation. So you need to know about that. So the electrocardiogram measures allow you to look at the electrical activity of the heart. So what we do, we take electrodes. We get electrodes and we attach them to the outer surface of the skin. We actually use 10 electrodes, but we get 12 leads, okay? So we put 10 electrodes on the outer surface of the skin, and we get 12 leads. So if you're going to make any reasonable assessment, you need a 12 lead ECG, okay, where you have 12 different electrical signals that are recorded at the same time. And we put one of the leads on the right arm. So, and you'll see, we're not going to write out, when you look at them, they're labeled and they're going to have RA, LA, that type of thing. It's not going to, not going to spell out the whole thing. So a lead is put on the right arm, left arm, right leg, the left leg. Then we have what we call, so these are what we call the limb leads. These are the limb leads. And then you have chest leads, V1, V2, V3, V4, V5, V6. You have to know how to place the leads. If you don't place the leads properly, you can give the patient false diagnosis. So we're going to show you where to put the limb leads, and then these are the chest leads. V1 is place the right fourth intercostal space, or the fourth right intercostal space. We're going to show you that. V2 is position the fourth left intercostal space. And then you don't put V3, you put V4 next. The mid clavicular line, the fifth intercostal space. And then V3 is positioned between V2 and V4. Okay, so everybody should get the should get the hands on and putting these leads on and be familiar with lead placement. V5, the anterior axillary line, the fifth intercostal space. V6, the mid axillary line, the fifth intercostal space. And this is what we mean. So you can put your limb leads like this, and this is probably the preferred method. However, if you're going to do something like this stress test and stuff like that, you can put your limb leads like this. Or if there's any amputation stuff, you can put your limb leads. So the right arm, so you should clean the surface with, preferably rubbing alcohol. Make sure the patient is not allergic to alcohol. So clean the surface carefully with alcohol. You have your right arm lead, the left arm, the right leg, the left leg. Okay, or you can put it, the right arm, you can put it in the shoulder, left arm, right leg, left leg. Okay, clean the area properly. Make sure the patient is not allergic to alcohol. Then your chest leads. So V1, as we said, okay, so you have to know how to count your intercostal spaces. So V1 is the fourth right intercostal space. So this is the first, the second, the third, the fourth. Right. So the right fourth intercostal space, V1. V2, the fourth intercostal space, the left. Okay, fourth left intercostal space. Then you don't put V3, you put V4. V4 is the mid clavicular line. This is your clavicle. You drop a line, a perpendicular from the mid clavicular position, okay, and the fifth intercostal space, that's V4. And then V3 is positioned between V2 and V4. V3 is right there. So V5, your anterior axillary line, the fifth intercostal space, okay? And then V6, the mid axillary line, the fifth intercostal space, okay? So you need to know the correct position for your lead placement. Again, if you position your leads incorrectly, you can give the patient false diagnosis. All right, so we're not going to spend too much on action potential, but whenever if a nerve fires or a muscle is stimulated, you have what we call action potential, and that's just a movement of ions between the inside and the outside of cells, which brings about electrical activation. Okay, in the heart, you have two types of cells. You have the conduction cells and the muscle cells, and there's action potential for each of those. But basically, it's the movement of ions between the inside and outside of the cells, which cause what we call depolarization. Okay, so you get electrical activation of the myocardium, and then the muscle contracts. So the movement of the ions will occur first. So there are different phases to the action potential. We talk about the rising phase, the peak phase, and the falling phase. So action potential looks like this. Okay, so this is your depolarization. Okay, this is what we call the plateau phase, and then you have the repolarization. Okay, so this is what the action potential looks like, and you need to get depolarization before the muscle contracts. So, okay, different phases. So we're not going to spend a long time on that. But okay, so again, in the heart is sort of unique in that you have specialized conduction system, and then you have the non the muscle, so to speak, or non-specialized conduction system, which is the cardiac muscle. Um, okay. The difference between stimulating the muscle directly and the specialized conduction system. The specialized conduction system, you have slow depolarization because it's a spontaneous activity. The heart does not need anything to to stimulate contraction. From the day you were conceived, the specialized conduction system, it starts firing. Anyway, so when so there are a number of things that goes on in the heart. So when you depolarize the atrium, so what I'm going to do, I'll show you the conduction system. The conduction system actually starts in just above the right atrium. We talk about the sinoatrial node, or the SA node, which is usually located at the junction of the superior vena cava and the right atrium. And when the SA node depolarizer fires, it causes the atrium to depolarize, via the same movement of ions that we spoke about. So when the atrium depolarize, so we're going to use depolarization and contraction as a synonymous term. But remember that depolarization is actually an ion phenomenon, and then contraction is when the muscle actually contracts. But anyway, atrial depolarization is depicted on your EKG as a P wave. So when the atrium depolarize, you get atrial contraction, and when you look at your ECG, you see P waves. Then when the ventricle depolarize, after depolarization of the ventricle, you get ventricular contraction, and that is represented on the ECG by QRS complex. So the QRS complex is a much higher voltage and broader complex than your P wave. Your T wave is as a result of ventricular repolarization. So when something depolarizes, it has to, if you just glance back, let's glance back at, so this is your action potential. So when it depolarizes, and it's mainly because of sodium ion moving inside the cell, and then you have the plateau phase. It has to repolarize. It has to sort of replenishes itself. Okay, so the replenishment of itself gives you what we call T waves. Are you guys still hearing me?
I'm here right now.
Okay, all right, good, no problem. Yeah, there's some problem here with the audio. So, all right. So the first thing to happen is atrial depolarization, atrial contraction. You get P waves. Then you get ventricular you get ventricular repolarization, but it's so tiny that you don't see it on the surface ECG. Then you get ventricular depolarization. You get your QRS complex. Then you get ventricular repolarization. So it has to replenish itself. Then you get the T wave. So when you look at your surface ECG, the P wave is due to atrial depolarization. And of course, the atrium is going to contract. Then you get ventricular depolarization, you get your Q, R, and S complex. So the first downward deflection is your Q wave, the first upward deflection is your R wave, and then the second downward deflection is the S wave. So the QRS, okay? Ventricular depolarization. Then the ventricle repolarize and you get your T waves, okay? When we talk about PR interval, and these are important measurements on your ECG, your PR interval is from the beginning, you have to know how to measure them. It's from the beginning of the P wave to the beginning of the QRS. Okay, that's a PR interval. And if you just think about it, as we mentioned before, the electrical impulse is going to start in the SA node. The SA node is at the junction of the superior vena cava and the right atrium. So it's going to start in the top of the atrium, and it's going to travel through the atrium, and it's going to get to what we call the AV node, where it's going to slow a little bit, and then it's going to continue down into the ventricle. All right, so this PR interval is a measure of how long it's taken from the atrium to get to the ventricle. So, and then you have to know how to measure it from the beginning of the P wave to the beginning of the QRS. And then another important measure is what we call the QT interval, which is from the beginning of the QRS to the end of the T wave. Very important measure, okay? So that encompasses not only ventricular depolarization, but also includes the ventricular repolarization. All right. And then we also talk about a PR segment, which is from the end of the P wave to the beginning of the QRS complex. So what you need to do, go over this and know your segments and your intervals. You have to know segments and intervals, how to measure them. And then ST segment, it is from the end of the QRS complex to the beginning of the T wave. And, you know, we talk about ST segment myocardial infarction, ST segment heart attack. So this is what we look at, the ST segment, which is from the end of the QRS to the beginning of the T wave. All right, so again, PR segment is from the end of the P wave to the beginning of the QRS, and then we talk about the ST segment from the end of the QRS to the beginning of the T wave. So go over your intervals and segments, know how to measure them. Okay, all right. So when we talk about a 12 lead EKG, remember you have 10 electrodes. You put on the electrodes and you get 12 lead. And so you have to know the leads. We talk about lead 1, lead 2, lead 3, AVR, AVL, and AVF. So these are the limb leads. And then your chest leads, V1, V2, V3, V4, V5, V6. Okay? So you know the chest, sorry, the limb leads with the A before them, the AV. These are what we call augmented limb leads. Augmented limb leads. So AVR, AVL, and AVF are augmented limb leads. Okay, and then these are just regular limb leads. So you have 6 limb leads and 6 chest leads. All right. So when we talk about a normal ECG, what we mean is that when you look at your ECG, you're gonna, so this is a P wave, your QRS complex, and T wave. P wave, QRS, T wave. P wave, QRS, T wave. So when we talk about a normal 12 lead EKG, or when we say normal sinus rhythm, a normal sinus rhythm means you have a P wave followed by a QRS, then a T wave. Your P wave is supposed to be upright in leads 2, 3, and AVF. Okay? and that's because of how the electrical signal is perceived. Okay, you know, the electrical impulse, as we said, it comes from the atrium and it comes straight down the heart. These leads are what we call the inferior leads, leads 2, leads 3, and AVF. Those are inferior leads. So those leads are looking at the electrical impulse coming towards it, and that is why the P wave is supposed to be upright. P wave is upright in leads 2, 3, and AVF. Okay? And then each P wave is followed by a QRS and a T wave. That will make it sinus. And then the intervals are also important because your PR interval, remember interval, your PR interval, which is from the beginning of the P wave to the to the to the beginning of the QRS, that's supposed to be less than 200 milliseconds. All right, and then your heart rate supposed to be between 60 and 100. That's what make it normal sinus rhythm. So if you're saying normal sinus rhythm, what you're saying that each P wave is followed by a QRS and then a T wave. Okay? All right. We go over that. Again, the reasons for learning electrocardiography in echo is because everything in echo is gated. Every single thing in echo is gated. You shouldn't do an echo examination unless you have your ECG leads on the patient. And what we mean by gated is that it's either systole or diastole. It's either a systolic phenomenon or a diastolic phenomenon. Systole is from the beginning of the QRS to the end of the T wave. Diastole is from the end of the T wave to the beginning of the QRS. You have to remember that. So when we're doing our echo, we constantly scrolling back and forth, back and forth. And the reason for that is because we want to know, if we see something, is it a systolic phenomenon or a diastolic phenomenon? Okay? So it's very important. Everything in echo is gated. Right? So yeah, you need to know that. So again, systole is from the beginning of the QRS to the end of the T wave. And then diastole is from the end of the T wave to the QRS. All right. How do we determine heart rate? So if you pick up an ECG, once it has grids in it, you should be able to determine the heart rate right away. A very quick way of determining the heart rate is to divide 300 by the number of big blocks between RR interval. This is your ECG on the bottom. This is your P wave due to atrial depolarization and atrial contraction. Your QRS, which is due to ventricular depolarization, ventricular contraction, and then your T wave, which is due to ventricular repolarization. Okay, so this is when we say RR interval is from one R wave to the next R wave, or from one QRS to the next QRS. That is what we call RR interval. And your ECG paper is grid. You have what we call big blocks and small blocks. So you just count the number of big blocks that separates the RR or the QRS. You divide 300 by the number of blocks, and that's your heart rate. Simple as that. Very simple. So if there's one block between your R waves, then 300 divided by 1, the heart rate is 300 beats per minute. If there are two big blocks that separate the R from one R to the next R, then you divide. Okay, we're not going to do questions just now. Questions is left for a separate time. But if there are two big blocks that separate one R wave from the next R wave, 300 divided by 2 is 150. Okay, so this is what the ECG grid looks like. So these big bright markings is the big blocks. These are your big blocks. This is what we call big blocks. Okay. So again, this is your T wave, P wave, QRS. T wave, P wave, QRS. T wave, P wave, QRS. Okay. So when we say RR interval, this is one R wave, this is the next R wave, this is the next R wave, next R wave. If you look closely, the number of big blocks that separate this R wave from this one, it's 1, 2, 3. It doesn't have to be exact because the heart rate is going to fluctuate close to that number anyway. So it would be 1, 2, 3. 3 big blocks that separates this R wave from this R wave, and similarly, very close. All right. So the heart rate would be 300 divided by 3. So it's about 100 beats per minute. Okay. So the heart rate is 100 beats per minute. So if there are 4 big blocks, it would be 300 divided by 4, which is 75. 5 big blocks is 300 divided by 5, which is 60. And 6 big blocks, 300 divided by 6, which is 50. You need to be able to do that quickly. If you look closely at your gridding, okay, one big block is actually 0.2 seconds, because the reason for that is because when you do your ECG, we usually do it at a certain speed, and that's another important thing. Those of you who read ECGs, you need to look at the sweep speed. It's supposed to be 25 millimeters per second, and then you need to look at the height of your waves as well. But the sweep speed is supposed to be 25 millimeters per second. All right. Sorry, 25 centimeters per second. So if you use that information, each of these big blocks, the big block is 0.2 seconds, which is 200 milliseconds. So the time from here to there, okay, is 0.2 seconds, which is 200 milliseconds. So if you look closely, you can see that there are 5 tiny blocks in each big blocks, 5 tiny blocks in each big blocks. So the timing for each tiny block would be 0.2 divided by 5, which is 0.04. So each tiny little box is 0.04 or 40 milliseconds. Okay? So you can use that information to get the heart rate more accurately if you so desire. But all right, so we talk about the conduction system. Again, when you were conceived, the same day you were conceived, your heart starts to beat, and you don't need any external influence. The heart starts to pump, and that is because you have specialized electrical circuits in the heart, which cause the heart muscle to depolarize and hence contract and relaxes. The SA node, sinoatrial node, which is what we call the pacemaker of the heart, is located at the junction of, this is your superior vena cava. It's located at the junction of the superior vena cava with the right atrium, SA node. Then you have specialized conduction system that travels through the atrium. So if you just think in the conduction system, if you think in terms of, say, electrical wiring, electrical circuitry, then you'll probably get a much better understanding. So you have the SA node here, and then specialized, tissue that conducts. So the electrical impulse which is generated in the SA node travels through the atrium through the specialized conduction system. It gets to the AV node, which is located close to the junction of the atrium and the ventricle, atrioventricular junction, So this is the AV node right there. The AV node gives rise to the bundle of His. Okay, the bundle of His comes down, then it splits, and you get a left bundle branch and a right bundle branch. And then these bundle branch fans out into what we call Purkinje fibers. And that is the electrical uh, uh, the electrical system of the heart. Okay, starts with the SA node, then you have some specialized conduction cells in the atrium. So the impulse generated in the SA node travels through the atrium, slows in the AV node. Okay, then you have the bundle of His, you have your left bundle and your right bundle, and then the Purkinje fibers. So that's the conduction system of the heart. Again, the SA node, electrical impulse originates in the SA node. It's called the pacemaker of the heart. Okay? But if the SA node stops functioning, then the AV node takes over. So the pacemakers can, even though we said this is the pacemaker, if it stops working for whatever reason, the AV node can take over. If the AV node stop working, then the junction lower into the conduction system will take over. The ventricle can take over if everything stop working. It's just that when the ventricle kicks in on its own, the rate is going to be too slow. So you're going to become symptomatic. All right. So that's your SA node. Electrical impulse travels through the atria to the AV node where the impulse is delayed, it's slowed. We talk about the bundle of His. After the electrical impulse passes through the AV node, it travels to the bundle of His. And then the bundle of His give rise to the bundle branches. Okay, so the electrical impulse then travels to the left first and then the right. Okay, travels to the left first and then the right. So you always remember that. And then with the Purkinje fibers, the bundle branches taper out to produce a Purkinje fiber. Purkinje fibers are then into the muscle itself, the ventricular muscle. So stimulation of the His-Purkinje system, that's what give you the QRS, because the His-Purkinje system is going to cause ventricular depolarization. Okay, so just go over it. All right, so all right, I'm going to stop here because the axis of the heart is going to take a little imagination. It's very simple, but we will leave that for our next session. So we're going to